Hello and welcome. UVA Speaks is a podcast of Lifetime Learning, a division of the Office of Engagement at the University of Virginia. Lifetime Learning brings the knowledge and expertise of UVA's faculty to the university's alumni, friends, and families. My name is Susan Lynch, and I am the Associate Director of Lifetime Learning at the University of Virginia's Office of Engagement. This podcast features Dr. Shawn Pelletier. He is a professor, chief of the Division of Transplant Surgery, director of the Transplant Service Line, and surgical director of the Liver Transplant Program at UVA Health Systems. Dr. Pelletier has been on faculty at UVA for 12 years. He's a leader in several professional organizations and has contributed to more than 100 articles in peer-reviewed journals. In this podcast, Dr. Pelletier will talk with us about organ donation and transplant services at the UVA Health Systems at the University of Virginia. So thank you, Doctor, for speaking with me today.
Susan, thank you. It's really a privilege to be here, and I appreciate the invitation.
Great, thank you. So first, I'd like to start the conversation talking about organ donation. In preparation for the podcast, I was doing some reading on UVA Health website. And when I think of organ donation, I think about the donations that are made by those who have died. And certainly that's a part of it, but living organ donation is also an important part of the work that you do. So could you provide us with an overview of both aspects of organ donation?
Yeah, and I think that's a great point of there's a lot of misunderstanding of the different groups and there's even subgroups, and I'll go through them a little bit if that's okay. One is the one that you just said. We categorize them as living donors or deceased donors. And even within those, we can separate them a little bit. For living donors, I think most people understand of potential friends or family coming forward and intentionally donating a kidney, often maybe part of their liver, to someone who's in need. So that's definitely one of the most common areas for living donation, but we'll also often have non-directed or anonymous donors. It's not too unusual at UVA that some learn the power of saving someone's life through organ donation, and for whatever reason might not be able to donate to the person they intended, or maybe they just learned about it online or from a friend. And they come forward saying, I am willing to donate either a kidney or part of my liver to anyone who needs it. So we do have, yes, I see your face. It's an amazing gift. It still amazes me how much, how giving people can be. And they come forward, to anyone who can benefit from it. So one is at UVA over the past year or two, we've directed the liver donors to taking the smallest part of their liver that can be used, which is the safest for the donor, and directing it to a small pediatric recipient. So they're really saving the life of a small child. And then when it's a non-directed kidney donor, we'll try to direct it to starting a chain. So there's within a computer database, there's a few of them. One, National Kidney Registry is one example, where someone can donate one kidney to someone. It goes into a computerized algorithm, and it'll often start dominoes going down where someone who had a donor that couldn't go to them, but could go to someone else. And one donor might lead to 40 or 50 people being transplanted throughout the United States, not just at UVA. So the power of living donation is truly incredible. And it's amazing and the patients who receive these organs really, really do well. So that's living donation kind of broken down. And then deceased donation also can be broken down to a couple groups. One, as you said, these are people who have died, so deceased donors. In the beginning of transplant, we started this is when I say we, way before me, started using organs from potential donors after their heart had stopped. The organs are removed right away, called donation following cardiac death, after the heart stopped. In the early 70s, they also came up with definitions of brain death. So in this situation, the heart is still beating. The organs that are potentially going to be donated are still receiving blood flow and are viable, but there's no flow to the brain. And I think as a society, we've all agreed if there's no blood flow going to the brain, literally, if you check an X-ray of the blood vessels, you do not see anything going above. There's zero blood flow. So the brain is dead, and we've now considered legally that person is deceased and will receive organs from brain dead donors as well. That's the most common type of deceased donor. But the non-heart beating donation following cardiac death is probably the area of fastest growth right now.
Thank you for that background. And yes, that's amazing. That's a real gift and an amazing thing that people are doing. That's great. It's my understanding that the need for transplant organs is far greater than the available supply. So can you talk with us about the importance of organ donation and some of the advances that are available now in organ donation?
Yeah, so the need, there's a real need for it. There's over 100,000 people, roughly about 103 to 105,000 people waiting on the list. That's a little misleading. There would be more if we had more organs. Transplant centers throughout the United States are really listing patients who they think are likely to do the best when they get transplanted. So since there's a limited supply of organs, we're trying to be good stewards of using them in the smartest and best ways. If we had an unlimited supply, we would easily be able to identify additional people who could benefit. So that 103,000 is a conservative number. There's way more people who are on dialysis that we might have been able to help if we had more organs. In the United States in 2023, there was roughly about 45 or 46,000 transplants performed. So we're not even meeting half the number of the organs that need to be done. To give some examples, the likelihood of dying on the waiting list to receive a liver transplant is somewhere between 15 or 20%. So the odds are still in the favor of people who are on the list, but that's still a high number of people dying without waiting. And then on the kidney side, I think a lot of people think of receiving a kidney transplant as something that takes them off dialysis, maybe gives them more time, better quality of life, but it actually extends life 2 or 3 times. The average waiting time to get a kidney in the United States is somewhere between 4 to 7 years. The average survival on dialysis is 3 to 5 years. So those numbers really don't add up quite right. The chance of dying on dialysis is quite high. It's worse than most cancers that people have. So the absolute need for more organs is really important. And I think then the next part of that question was, it the benefit of transplant?
And some of the advances that are happening now within organization. Mm-hmm.
Yeah, organ donation is really starting to continue to evolve and increase. Alden Doyle is one of our transplant nephrologists here at the University of Virginia. He's been identified by the U.S. government, by HRSA, to find ways to use organs in a more expeditious way. He's the co-chair on a committee. And that committee has set a goal in the United States to increase the number of organs being donated from about 40,000 to 60,000 over the next few years. So there's a lot of emphasis on trying to find the best way to increase these numbers. One of them is using machine perfusion. So we've been removing kidneys, connecting them to a machine that pushes cold preservation solution through them. It kind of flushes out the kidneys, removes toxins. It gives us some flow dynamics to get ideas of how well the kidneys would recover if you did use them for transplant, so we can select the right ones. And we've been doing that for decades. This machine perfusion for other organs is now really starting to take off. We now have machines to be able to do this similar type of preservation and evaluation for hearts, lungs, and livers. And even it's getting to the point that we can now use organs that otherwise would not have been possible in the past. To give you some of the better examples, The very first transplants for heart used donation following cardiac death hearts. Obviously, that's a risk. The heart has stopped beating. It's not had blood flow through it. You have no way to evaluate if it's working. Now we can connect the heart to a machine outside of the body. It's literally, you can watch it. It's just the heart with blood being pumped through it. It starts to beat again. You can evaluate how the heart is recovering, identify if it's safe to transplant. It gives you a little bit longer time to travel from the donor hospital to the recipient hospital, so you can procure a heart from further away. Similar, less dramatic for liver. It just kind of sits there like a blob and makes bile, but the effect and benefit is just the same. That the liver turns pink. You can see that it's functioning. The liver makes clotting factors, so you actually have to put blood thinners into the circuit that pumps blood through so that the liver doesn't clot off. It kind of proof that it's working and doing what it needs to do. And then the similar areas for lungs. So this type of technology now at a few centers that have really pioneered it. We were involved for the lung and livers during the original research. And now the centers that are really bringing it to the clinical reality have demonstrated that they can, in some cases, increase the number of people receiving transplants by 50% or even 100%. So this is all helping us be able to expand the donors we're using, including the donation following cardiac death, the non-heart beating donors. So that's probably one of the hottest areas in organ donation right now. Another area is the donor care unit. And it's the concept of, instead of having someone who's a potential organ donor staying at a smaller local hospital, is to, instead of bringing all of the transplant experts to that small local hospital, of bringing the donor to a center that has an expertise and managing the organs, recuperating some of the organs, and increasing the amount that's likely to be able to use to help other people. And I can say that that's a lot of effort. You know, you don't think of having your loved one moved from one center to another to be a potential donor. On the other hand, almost unanimously, donors and their families say that they want their potential donation to be used in the best way possible and to help as many people as possible. And by using these donor care units or donor care hospitals, it increases the number of organs from a potential donor by almost one, maybe an extra kidney, maybe the liver or heart or lung. So it's really saving an additional life by using this type of technology. There's another area called normothermic regional perfusion. Sorry about all these names.
No, this is great. Thank you.
It uses the acronym NRP, and really it's a heart-lung machine. So I think many people know that if you go for heart surgery, they stopped the heart from beating so the cardiac surgeons can operate on the heart. The rest of the body is receiving blood flow from it being pumped from a machine, and also getting oxygen from the machine as well, replacing the lungs. So in a donation following cardiac death donor, after the heart stops beating, we can connect them to this ECMO machine or our heart-lung machine, restore blood flow specifically to the organs that we want to procure. It might just be the abdominal organs, the liver and the kidneys, or also potentially the heart as well. The lungs can get their oxygen from continuing to ventilate, so they are not quite as critical as requiring the blood flow as well. So we're still really figuring out how we cooperate between different organs to figure out to maximize the benefit. But again, that gives you the same type of benefit to these. We're now seeing areas where in the past, we would say if a donor for a DCD liver, for an example, if the donor was older than 60 years old, which is not that old, as I get closer to that, not quite there yet. But if the donor was over 60, we would consider that liver too high risk for the recipient to use. We'd worry that the bile ducts would develop scar tissue, that the person would need a second transplant because that first one failed 3 months, 6 months, maybe a year down the road. Now we are kind of going way beyond those boundaries, using livers beyond DCD livers, way beyond that routinely, and able to help other people that we wouldn't before. So as I mentioned, we can where this potential is going to stop, we're still figuring out. Because we really want to protect the safety of the recipient, we want to slowly increase those boundaries and see how far where that edge of safety stops.
That's amazing. Thank you so much for sharing all of that. It's such important work. So, you had mentioned to me that there are some controversial aspects to organ transplantation, and can you put some of that into context for us?
Yeah, I think the last question, that's a perfect segue. That the idea of resuscitating a donor after their heart has stopped has really brought up a lot of questions. And transplant's a field that always is pushing the limits. The best example I can give, in the distant past, if someone died, whether it was this minute or 5 minutes or an hour from now, it didn't change how you helped that person or managed that patient or took care of them after their death. For transplant, if we're going to use the organs, if there's no blood flowing through them and they don't have preservation solution and they're not cold or they don't have blood flow, they're getting injured. So the longer that they're injured, the less likely they're going to be used for transplant. So we really wanted to know the minute, if not the second, that death had occurred. So transplant, just by nature, has always been trying to push the limits and the definitions, but also doing it in a way that's ethically right. There's a rule called the dead donor rule. We do not, other than the living donor, where we do it with permission, we do not remove organs from someone unless they are known to be dead, legally dead, physically dead, and ethically everybody agrees. Mm-hmm. So now we get into this situation where we know we can save at least one more life per DCD donor if we use this device, the NRP, the heart-lung machine. On the other hand, the person has been declared dead because their heart stopped and it was irreversible. So now we pump blood through and the heart starts beating. And there's a concern is, does this still fit the definition of death? For us, the definition of death was that the event was not irreversible. This is by an artificial means. So this is different than the heart starting spontaneously and beating again. There's also, discussion of it's probably reasonable to do this for the abdominal organs without having blood flow restored to the heart where the heart starts beating again. And all of this is really going through a national debate at this time and trying to find ways that we can do this where clearly it's acceptable. We want to, as I said, always follow the dead donor rule, but also maintain support by the community, and so that we continue to have the support of those who would want to consider being potential donors. That's probably one of the biggest debates right now going on in organ transplantation.
Yeah. Thank you so much for sharing that context. I think that's very helpful for all of us to think about. So thank you. Now, can you talk with us about UVA's transplant services and the comprehensive team of providers that serve patients and their families?
Yeah, I think this is why people who go into transplant, that it's really a community coming together to save lives using transplant. And that community, we talked a lot about organ donation. It's the community at large, considering being potential organ donors, living donors, the families that come forward to support them. And then it's the transplant team here at UVA. We come through in a comprehensive fashion. If someone comes in to be considered for a transplant, they routinely are meeting a physician who's an expert in that organ failure. For instance, a cardiologist for heart, pulmonologist for lung, nephrologist, hepatologist for kidney and liver. Meeting the surgical team, identifying, how can we do the surgery safely? How can we help them recover? We have literally at UVA the best nurse coordinators in the world. I've never worked with a team that's as good as the group here today. We also come through with our pharmacy team, our social work team. What's impressed me the most, I think surgeons have, by nature of what we do, we feel like we are doing surgery to a patient, and that we feel a true sense of responsibility for that person and their well-being. And what's really cool at UVA is our entire team comes through with that same dedication. I left out our financial coordinators, just take it to a whole new level. It's really, and then the last part, which we could not do this without either, is the entire hospital administration has recognized the importance and the power of transplant and help us to make sure we have the resources we need to do our job well. So it's a great time to be part of the transplant team at UVA right now.
That's great. My sister's a nurse up in the DC area, so shout out to the nurses.
Yep, I'm with you on that. Couldn't do it without them.
So thank you. And finally, as I mentioned, you are the surgical director of the Liver Transplant Program. So as we close out, can you just tell us a little bit more about this program and some of the advances in liver transplants? You talked about it a little bit, but if there's something you'd like to share.
Yeah, and I'll touch a little bit of we're evolving in machine perfusion for livers and increasing the expanding which livers we can use safely to help more people. We have a donor care unit at UVA. The liver team has really been one of the more successful programs in the United States with non-directed anonymous donors. And as I mentioned, kind of helping small children and making the operation as safe as possible for the donor. We are in the process of developing what's known as transplant oncology. And this is an area that's largely involves liver, but can also involve other organs as well. You can imagine if you have a tumor in your liver and you want to get it out, removing the entire liver and replace it with a new one is almost going to guarantee getting all of it out of there. So we do that routinely in the United States and really everywhere in the world for certain cancers, such as hepatocellular carcinoma. We now have a program combining the resources of our living donor program to do this for colorectal cancer. We're one of the few programs in the United States and the only one in the mid-Atlantic area doing this. And so those are kind of the areas that we've been advancing probably the most over the past year or so.
Great. So thank you so much, Dr. Pelletier, for sharing all of this information about organ donation and transplants at UVA Health System. You and your colleagues are doing important life-saving work, and I appreciate you taking time out of your very busy schedule to share your knowledge and expertise with UVA's alumni, friends, and families.
Yeah, it's my privilege, and I encourage everyone out there, consider being an organ donor, and we really appreciate all of your support. Thank you.
Okay, great. Thank you so much. And thank you for listening. For upcoming podcasts and other lifetime learning programming, recordings, and blogs, please visit our website at engagement.virginia.edu/learn. You can also find our podcasts on the Virginia Audio Collective, which is a network of UVA podcasts hosted by WTJU Radio and can be found at virginiaaudio.org. So thank you again, and we look forward to you taking part in future lifetime learning programs.